Good afternoon, everybody. Welcome to this session on health and taxation in developing countries. My name is Bert Bries. I'm the head of the country tax policy unit in the OECD, and I'm happy to be your moderator and of this session. The session is briefly organized as follows. Céline Collin, a tax economist in CTP, will be giving this presentation on health and taxation in developing countries. There will be, during her presentation, 2 polling questions that I will read out, and you will get the opportunity to answer that question, and then we will briefly give you the answer of the question. Afterwards, at the end, there will be 2 interventions of 2 guest speakers. First, we will have Michele Cecchini, a senior health economist in the OECD, and afterwards, Gioia De Melo, who is a tax economist also in the Center for Tax Policy and Administration. I will be monitoring the questions that are posted in the chat, and we have already received some separate questions before, and we will, at the end of this session, I will raise these questions to Céline and colleagues, and we can try to answer these questions. Next slide, please. Before I give the floor to Céline for the presentation, just as a warming up, some 2 inspiring quotes of 2, let's say, wise men. Let me point out here very beautiful quotes, but these quotes are to some extent like what I would call inward looking. And what we've learned recently is that health and health challenges are a truly global public good, which require adjusted action. And that's part of the reason why we have this health tax session. Céline, the floor is all yours.
Thank you, Bert. Thank you very much. So country officials in all countries face the same question: how to better finance health system. That question was already a difficult one prior to the pandemic. Now in the current setting, this has become even more of a challenge. So one can wonder, why are we discussing this question today at the OECD Tax and Development Days? Well, the answer is because of its international dimension. First of all, health systems are interconnected. We all know that health challenges do not stop at national borders. Obviously, COVID-19 is a perfect example of that, but let's also remember of Ebola and Zika not so long ago. It's also very clear that in the globalized world, with high mobility of individuals, population health status in a given country has consequences on its neighboring countries. We know that the COVID-19 pandemic led to massive disruption in the health system services, including for important diseases such as HIV, TB, and malaria, especially in the developing world. And at a global level, epidemics such as HIV being on the rise again is simply not a good news. Finally, climate change will create massive health challenges in most, or I should even say, all countries. Second, to illustrate my point, let's have a look at what's going on the tax revenue side. And we know that all countries need to protect their tax base. Let me just provide here one example to illustrate my point. If you think of health taxes, so health taxes which are levied on products that affect health, important rate differentials across countries, in particular across neighboring countries, can lead to cross-border shopping. This has been observed in the Baltic countries, but also within countries when such taxes were implemented at the city or at the province levels. It can also lead to illicit trade, especially for tobacco, but on this we also know that there are many other factors playing, such as insufficient control capacities, but also governance issue when it comes to illicit trade. But in any case, both phenomena will lead to an erosion of tax revenues for countries. And that is why some part of the world are trying to implement solutions at the regional level, such as in the Gulf countries, where there is a very strong willingness to fight against obesity and overweight trends by increasing drastically taxation of SSVs. those regional initiatives should definitely be pursued. So now let's have a little look at the macroeconomic context. And obviously the difficulty for developing countries is that on average, public finances are under pressure. The graph on the left-hand side shows you the budget deficit as a percentage of GDP for emerging and low-income economies. And what we observe is that for both groups, they have deteriorated during the crisis and will reach their pre-pandemic level only in the medium run. The graph on the right-hand side shows public debt as a percentage of GDP, which are also on a rising trend, especially for emerging economies. So we all know that the crisis has put tax revenues under severe pressure, while at the same time requiring increased funding for the health sector. The starting point was already worrisome. That's the graph on the left-hand side, which shows that on average, the level of health spending per capita before the crisis was low. For low-income country, it was less than 50 USD per capita, which is 60 times lower than high-income country. Now with the crisis, the demand for health public spending has drastically increased. And that's the two other graph. This is work done by the World Bank based on IMF projection. And basically it shows you the green bars, additional spending needed in the health sector by 2026 for different income groups, if you would want to follow the same trends as the decade before the pandemic, in talking about here health public spending. Conclusion is there is. So to the difficult question on how to better finance health system in the context of an economic and sanitary crisis, the generic answer is threefold, and that's what you can see here on the slide. Number one, by increasing general tax revenues. And here part of the solution will be to carry out ambitious tax reform to be implemented gradually over time, touching upon all different types of taxes. Obviously, countries will also have to fight against tax evasion and illicit financial flows, but also to make the most of automatic exchange of information. Number two is by increasing revenues from health taxes. So here we mean taxes that are levied on goods that negatively affect health. What's interesting here is that for many developing countries, especially in Africa, that have implemented a broad tax package reform over the years, they all had health tax measures implemented successfully towards the beginning of the tax package. The fact that it was introduced successfully was really a way to get support and political buy-in for the rest of the tax reform package. Number three, by increasing revenues from health-related taxes. And here we mean environmental taxes, but also health social security contributions. What's interesting is that often countries do not use environmental taxes to their full potential despite their double dividend. Double dividend in the sense that those taxes will have a positive impact on environment and health outcomes in the long run, but also will help to raise more revenues and also to diversify the tax mix at the same time. That being said, countries are not unique in the tax policy challenge they face, and therefore country-specific analysis is required. And that's what we've been doing together with the financial support of the Global Fund to fight AIDS, TB, and malaria. We conducted those two reviews in Ivory Coast and Morocco on how to mobilize tax revenues to finance the health systems. Let me take this opportunity also to thank the Global Fund for their support and for the very interesting work that we did together. I'm going to stop here for the time being because we're going to have the polling question, and over to you, Bert.
Thank you, Celine. So first polling question, we have two. The first one, you will see a pop-up, I don't know, a voting button, or how do you call that, where you can actually provide your answer. So please do so after I've read the question. The question is, how many jurisdictions in the world have implemented a tax on sugar-sweetened beverages. Less than 30, 30 to 70, 70 to 100, or more than 100 countries. We're slowly converging to everyone having submitted the answer. 5 seconds more. And then, Celine, we turn to you for the answer.
Thank you. So I'm going to ask the technical team to show the answers. I hope you can see. So we have about 49% of participants who think that's below 30, about this 40 for between 30 and 70, and the rest is above 70 and even above 100. Well, so actually the solution here is 47. So 39% of participants were correct. Let me continue the presentation. I hope you can all see the slides. So 47 countries in September 2021 had implemented SSB tax. So what's interesting is to note that over the past years, the number of countries that have introduced the SSB tax has drastically increased. And that can be explained by the fact that clearly evidence of unhealthy diets on health have become more prevalent, but also because countries that have introduced such taxes did it in a very successful manner. And recent evaluation showed that in particular, I'm thinking here of Mexico, but also South Africa and Saudi Arabia with a very recent evaluation of those taxes. What's interesting is not to stop here, but to think on the other way around. That means that the vast majority of countries in the world do not have a SSB tax in place. And therefore, that clearly shows that the introduction of such taxes should continue in a not too distant future. In particular, because countries face or will face rising obesity and overweight trends in the year to come, because food habits change with urbanization and increase in income. So there is clearly a need to act preemptively, especially when you think of protecting children and the new generation from those obesity and overweight trends. I think we're going to go to the second question.
Second polling question, so same mechanism, you will be able to answer again. In 2020, how many countries have raised tobacco taxes to a level at or above 75% of the price of the most sold brand of cigarettes, which is exactly the WHO's recommendation to have a price at or above 75% of the price. So how many jurisdictions have implemented this WHO recommendation? Five more seconds, and then it's back to you, Celine, to bring some light in the dark.
I think we can show the results. Thank you. So almost 50% of participants answered between 10 and 50, and that's actually the correct answer. It is 40. So that's indeed in itself a nice result, but that also shows that there is still a lot of work to be done to increase rates on tobacco worldwide. So let's continue the presentation. And for the rest, I'm going to focus mostly on health taxes. So first question is, how much revenues are we talking about here? For the developing countries for which we have detailed information breakdown, health taxes revenues represent between 2 and 5% of total tax revenues and are on a rising trend for lower middle income and upper middle income groups. Expressed as a percentage of GDP, we see similar trends. We talk about lower shares. Please note that these results are likely to be underestimated because we do not have detailed breakdown information for all countries, but we are working towards having more country coverage. What it shows is that clearly there is potential for increasing revenues from health taxes if countries would increase the rates or broaden the base of the health taxes that they currently levy on unhealthy consumption, but also if they would enlarge the base for taxing other unhealthy products when consumed excessively. Let's think here, for example, of food that is high in sugar, salt, or fat. But also if the countries would tax the inputs that are used in the production of those products. What's interesting is to note that since the beginning of the COVID-19 crisis, many countries have or are considering increasing the role of health taxes in order to help restore public finance, but also to better finance the health care system. And here we can mention the case of Bangladesh, Egypt, Fiji, but also Ghana, Kazakhstan, India, Indonesia, and many others. And measures range from the introduction of specific COVID-19 fees on tobacco or alcohol consumption to the introduction of new taxes, in particular of SSB taxes, or increases in health taxes rates. What's also interesting is to compare the revenues from health taxes with public health expenditures. And that's what we do here on this graph. And what we can observe is that for some countries, the share is actually relatively high. That's the case for Philippines, Uganda, Mauritius, and Egypt. It does not mean that those countries allocate entirely the revenues from health taxes to the government health expenditures. Here, what we do in this exercise is simply to compare the two variables. So a key takeaway from this graph is not that all health taxes should be earmarked to the health sector. Instead, it shows the potential of those revenues if they were entirely earmarked, which is in itself a very strong assumption. It could represent, in some cases, an important share of government health expenditures. We also observe diversity in health taxes revenues across countries. Let me here focus on three different examples. First, you have countries that have a broad health tax base. That means that those countries tax the usual suspects, so SSB, tobacco, and alcohol, but also other products such as coffee, tea, sugar for industrial use, etc. And here we have three examples. Second, we have a group of small island states, and those countries have above average health taxes revenues. And that can be explained due to their geography. Obviously, being an island makes it more difficult for cross-border shopping or illicit trade, but also the economic structure and the fact that they rely a lot on tourism and tourist consumption. Finally, there are countries with a very well-defined earmarking policy, such as Philippines or also Thailand. In the case of Philippines, since 2012, the country earmarks part of the alcohol and tobacco revenues to universal healthcare. And more recently, the country has decided to also earmark part of the SSB and also e-cigarette tax revenues to the health sector. Again, given the context of the crisis, more countries have considered earmarking part of their revenues to healthcare system as part of their policy responses to the crisis. And that's notably the case in Ghana, but also India or Indonesia. Designing health taxes is far from being an easy task. And here, let me just highlight a couple of points on what to think when you want to introduce or revising the design of such a tax. First question is what to tax. And here the answer is very simple, the harm factor. In the case of alcohol, that's ethanol. In the case of SSB, that's going to be extra calories. Second question is what's the end objective? And if the goal is to reduce consumption, then what's really key is to make sure that the product is less affordable for the consumer. That means concretely that the price increase should be sufficient so there is a high increase in the retail price for the end consumer. So WHO, for instance, recommends in the case of SSB that governments impose taxes that will increase the retail price by at least 20% so that there is an overall effect on consumption and population health. This has very concrete repercussion. If you think of a specific tax, the key design aspect will be to make sure they are linked to inflation and income growth, so that, and also adjusted regularly so that the product is not, does not become more affordable with time. A third question is how to tax. Many possibilities at Valorem specific. Usually for health promotion objective, you prefer specific, but my message here is really that the tax design and what the country will decide has to be coherent with, number one, the goal of the tax, whether you want to raise revenue or whether you prefer, whether you have a health promotion objective, which is prominent. You need to make sure it's coherent with the specific population group you target, especially if you think of the young, in particular because that group can have different consumer patterns than adults or middle class, but also finally also with the tax administration capacities. If we think again of specific taxes, which are usually better for health promotion than ad valorem, let's keep in mind that those taxes are also more difficult to administer. Then how to define the tax base? You need very clear criteria. In the case of tobacco, a question is, are you going to tax new and emerging nicotine products? Question mark. In the case of SSB, are you going to include milk, water, diet drinks? That's also a question to analyze before you introduce such a tax. Then there is the obvious question of the tax rate. Do you go for a single tax rate or do you go for progressive rates? We know that progressive rates usually, if I take the example of alcohol, will have a stronger effect on decreasing the alcohol consumption. But if you do opt for such rates, then the question is on how do you differentiate? Are you going to take only into account alcohol concentration, or are you also going to look at other product characteristics, such as the producer size, for example? Also, this has a very strong link with tax administration capacities, because we know that a tiered system are more difficult to implement and enforce, in particular because it's going to be more prone to tax optimization schemes, let's say, by the private sector that will always try to look for a decrease in their tax liabilities. Then there is a question on the level. Do you want a gradual progressive increase or a sharp one-off increase in your tax and your final retail price? If you go for a gradual approach, well, the risk is that consumer might at the end not really feel the price increase, and the signaling effect of the tax might decrease over time. If you go for a sharp one-off increase, you might face strong private opposition at the beginning. However, you will also manage to reduce strongly the product affordability, but after a while, you might reach a plateau where nothing really changes except if your tax is indexed on inflation. Then at what level should the tax be implemented? Well, here the answer is to say nationally is always better. However, if it's not possible, in some cases, a local tax or a state tax will be better than the non-tax scenario at the national level. What's the tax incidence? That's a very crucial question and also a very difficult one. Who's going to bear the burden of the tax? Is it the industry going to absorb the whole shock, or will it be passed through to the final consumer? It all depends. It depends on the product. It depends on the country. It depends on the market structure, and also obviously the industry strategy. And that's why it's so difficult for countries to anticipate with great precision and sufficient confidence on the impact of the health taxes, because you simply cannot predict with full certainty how the private sector is going to respond. Final question, are health taxes coherent with the current tax system? Let me just illustrate this point with a concrete example. If you have excise or health taxes on SSB and alcohol, but at the same time you have a reduced VAT rate on those two products, well, it's not necessarily very coherent from a global tax point of view. So in that case, you might want to go towards the abolition of your reduced VAT rate. That's what Spain recently did last year, and they increased the VAT rate on SSB from 10 to 21%. That's exactly what I'm saying here. So I understand. I know that I raised a lot of questions, many more things to cover. I just wanted to highlight the coverage of the question and the analytical thinking that a country needs to have beyond introducing health taxes. But it's not only the tax design that is difficult. What's also very complex is to pass the health tax measure, and you need a lot of dialogue with different stakeholders. First of all, among Ministry of Health and Finance, there is clearly a need for a close technical preparatory work to be done jointly with both ministries. That's needed to feed in the public debate around introducing health taxes or revising their design. If you take again the case of Spain, especially Catalonia, that introduced the SSB tax not long ago, it went well because the two ministries worked closely together. And if you think of other countries such as Colombia with the reform of tobacco taxation a couple of years ago, it worked also very well because ministries were aligned and did a lot of prep work jointly. There is also a need to dialogue with the private sector. In some countries, the goal of the tax is really to encourage product reformulation and substitution towards healthier products. Here, if we think of the UK with the sugar levy, based on a tiered system relying on the sugar content of the product, the government led 2 years between the moment they announced the tax and the moment they actually implemented the tax, which gave sufficient time for the industry to readjust the products and to make sure the product were less strong in sugar. And that's a key explanation of why the sugar levy in the UK was so successful in terms of reducing sugar consumption. Dialogue with the population, that's also very important. Let's not forget that we are in the middle of a massive economic but also social crisis. What's interesting is that there is a recent study from the IMF that showed that the experience of the COVID-19 pandemic has increased public concern for climate change and public support for green recovery policy. In itself, that's a very good news. However, it does not mean that introducing taxes, including health taxes, is going to be an easy task. Some countries have recently faced massive opposition to tax reform or to increase in taxation, increases in energy prices. In addition, let's not forget that we are in an inflationary context. So all of this point to the fact that introducing a tax or revising the design of a health tax is simply not going to be as straightforward as it may seem. So solution to that difficult issue is soft earmarking. It might be the time to go for soft earmarking of part of the revenues from health taxes to the health sector. People might be more inclined to pay for those taxes if they know how they are being used. That being said, that would put additional pressure on the government to spend the money efficiently and to ensure solid policy results. With neighboring countries, we touched upon this issue at the beginning of the presentation. There is clearly a need for regional dialogue and international dialogue on health taxes with a goal to reduce tax disparities and fight against cross-border shopping, but also illicit trade. Finally, with international organization, because in some cases, countries need technical expertise on health taxes or sometimes they need an external stakeholder that will provide views on the different policy options that are available to the country. So what's next? There is clearly a political momentum behind health taxes that should not be missed. Before the crisis, health considerations were often not enough at the center of the political agenda. And now it is. It is in the mind of ministries of finance, but also heads of governments. And the question is, for how long? That's why the OECD has developed country assistance to help countries to improve the design of their health taxes today, looking at different items, such as the recent history of tax policy, the broad tax policy setting, the current design of health taxes, and finally, very important point, the tax administration capacities. In addition, what's really key is to estimate the revenue potential and the health outcomes from an increase in health taxes. But on this very last point, let me open the floor to Michele Cecchini, who is a senior health economist from the OECD Directorate for Employment, Labor, and Social Affairs. Michele, over to you.
Hello, everyone. Thanks very much for this invitation. It's a pleasure to be here with you this afternoon and bring the health perspective into the discussion. As was introduced, I lead the work at the OECD on public health, and the scope of our work is really to promote better policies for healthier lives. OECD, as you know, is an economic organization, and we work on the link between health bringing to wealth. Some of the statistics that give you an idea of why the two things are so closely related are that 10% of the GDP is currently spent to pay for health across OECD countries. Significant share is also spent beyond OECD. People with diseases have lower probability of being employed and participate actively to the workforce. So people with diseases tend to have lower productivity. For example, we have calculated that a person with diabetes has an additional week of sick leave per year compared to a person without this chronic disease. More importantly, these risk factors, such as tobacco consumption, obesity, or harmful alcohol consumption, are closely related to the educational attainments that children have through their school career. And this put a negative impact on the future human capital of a country. The team that I lead, the public health team, mainly works on three areas. The first area is to evaluate the impact of health on the economy and the key public health and other key public health threats, whether these are chronic diseases such as diabetes, cancer, cardiovascular diseases, or infectious diseases such as COVID-19. The second area in which we work is to understand what are the policies in place in the countries, identify policy gaps, and best practices that country can share and country can implement, borrowing this best practice from another country. The third area of our work is really to evaluate what would be the cost of strengthening the policy and its return on investment. Most recently, we have looked also at how best transfer policies across countries and how to help countries adapt a policy that works particularly well in a country to their own specific context. Most of the work we do is modeling based, and over the year we have become leaders in modeling the impact of public health action. We use among some of the most advanced techniques such as micro-simulation model or deep learning technologies such as neural network. Essentially, we use this approach because they allow us to help countries understanding and having strong evidence on the cost of a new policy, the impact on population health of this policy, the return on investment, and when will the effects shows up. As you can imagine, given the multitude and the complexity of interaction of causes of ill health, most of our work is interdisciplinary and in a way or the other covers areas that go beyond the classical health aspects. Just to mention an example that is very relevant for today is that in our most recent publication on tackling harmful alcohol consumption, we looked at the impact of a 10% hike in the price of alcohol products following a raise in taxation. And we carried out this analysis for all the OECD countries, but we went beyond the OECD countries, also including analysis on G20 countries and other countries with whom we work. Similarly, we have ongoing work on tobacco taxation, and in the past, we carried out work on sugar-sweetened beverages, particularly in the context of South Africa, for example, when the country implemented the policies. We are also in discussion for additional work in this field. All this to introduce what I think is the main message that I would deliver today with my intervention, and that's that I see a lot of complementarity and potentially great advantages for countries from the work that the Center of Tax Policy and the Public Health team could do together. Specifically, I see at least 3 advantages for a closer interaction between these 2 parts of the OECD. The first advantage is that we have common interests that are aligned, and we share a common view. Our constituencies, whether these are ministries of health or treasury, share a common interest in this field, and on this matter, the priorities really go hand in hand. Let me also mention that as other sectors in the government may have different views on these matters, joining forces will help us make the case for more action in the direction that treasuries and ministries of health wish. The second area is that we have complementary competencies. Let me explain what I mean with an example. As I mentioned 30 seconds ago, we have recently evaluated the impact of a 10% hike in the price of alcohol following taxation. We carried out analysis in terms of how healthier people will have a positive impact on healthcare expenditure of countries, how the workforce will be more productive, how this down the line will affect the GDP. However, our analysis was not able to advise countries on how to modify taxes to reach this objective. For example, on whether this is better to obtain the hike from an increase in exercise or other means, and fundamentally all the questions that Celine mentioned in her presentation. These are issues that the CTP has a lot of knowledge on and on which we could work together. The third and last point is that we can produce a much bigger impact, not just on member countries, but internationally by working together. The OECD is already highly regarded as the leading organization for tax-related matters and for work on the economics of public health. Outputs from the Committee of Fiscal Affairs and the Health Committee are used by countries beyond the OECD constituency and by other intergovernmental organizations to feed their work and the implementation of new policies. By joining forces, I think we can reach a critical mass that may produce a bigger impact. This last point in particular, reaching a critical mass and having a bigger impact by doing so, is in close relationship with the last issues that I would like to discuss today with you. On health tax matter, it is essential to adopt a regional or international approach. Otherwise, the impact of any new action may be severely hindered. There is plenty of studies that looked at how differences in prices among countries for health-related products hinder the impact of a new taxation. I'm sure that if we ask today to people coming from Nordic countries or the United States to discuss their own experience, they could tell us how changes in taxation on alcohol products or tobacco products were affected by the policy in place in bordering countries or states within the United States. In some cases, countries or states had to repeal the tax because of cross-border shopping. I hope that all the points that I made in my intervention help you understand why I think that there is a strong case for improving cooperation across CTP and the public health team, and for identifying synergies and common areas of work. On my side, I definitely see a high potential for making the OECD the leading organization for health tax matter by working more closely with colleagues in CTP and countries. Thank you very much for your attention. I stop here.
Thank you. Thank you very much, Michele, for your kind words and interesting presentation. Let me continue. Second, the OECD strongly believes in capacity building in relation with health taxes by training officials from Ministries of Finance and Health on the very specificities of health taxes. We touched upon some of the design issue earlier on in the presentation, but obviously there are many more grounds to cover in those trainings. In addition, the OECD shall develop a self-assessment tool for countries to be able to assess the sustainability of their health financing policies with a very strong focus on health taxes. Finally, the OECD aims at putting health taxes and health sector financing in the broader context of social protection financing. And on that topic, let me introduce my colleague, Joya De Mello, who's a tax economist on the project and the project leader of the Financing Social Protection through Tax Reform in Developing Countries project. Joya, over to you.
Thank you, Celine. As you well mentioned before, health taxes can help to partly finance health systems. I would like to briefly another stream of work that we're developing, which is linked to health taxes. And as you said, the project we are working, it's called Financing Social Protection through Tax Reform in Developing Countries. And it has been financed by the Swedish International Development Cooperation Agency, SIDA. So the project aims to cover three main objectives. The first one is to map developing and advanced countries in terms of social protection coverage, expenditure levels, and the financing schemes countries have, among other indicators. Second, we estimate countries' social protection gap, that is the effort they would need they would require to achieve universal coverage. And third, and most importantly, we develop a tax revenue framework that identifies how countries can fund this gap over time through a broad range of tax measures. So in a future phase of this project, we will aim at applying this framework to in more detail to specific countries. So please do not hesitate to contact us should you be interested in having your country being covered. And also, as part of the current project, we will organize free webinars where we will discuss challenges and opportunities that countries have faced trying to strengthen social protection financing. So we would very much welcome you contacting us in case you're interested in participating. We believe assessing how to finance social protection is nowadays of vital importance, especially as challenges including aging and climate change will be putting more pressure on social protection financing in the near future. So we thank you very much for your interest, and over to you, Bert. That's my presentation. Thank you.
Thank you very much, colleagues. Let me conclude with two observations, two conclusions, two points that I want to raise. First, there's obviously now an enormous momentum to make global health tax reform happen. It has become, as Celine has presented, there were already before the crisis great challenges in developing countries to develop in a fair and efficient manner their healthcare system, to roll it out, to ensure that the entire population has access to good health care quality and a good healthcare system. The pandemic has only increased these challenges further, and it has clearly demonstrated that health is a global public good. As Celine argued, your countries, your neighboring country's health crisis is your own country's health crisis because of the transmission of viruses that goes very quick, as we all know now out of experience. This is also linked to climate change, which will create its own challenges as well as create health challenges, in particular in the countries which will be hit the hardest, which will include many developing countries. So there is clearly a momentum, a need to develop and to help and assist developing countries to help them finance and to work together with developing countries so they can finance their healthcare system before, and to make sure that we are ready for the next crisis. That doesn't want to be sounding as like a doom scenario, but I think that is objectively an important goal and an important objective that we all should try to realize. In particular, also because many countries, because of COVID, will be facing increased debt levels and further pressures and other spending needs, which also will need to be met based on public resources which are scarce. So there is a global need, and we are working on this intensively, and we are very ambitious, to be honest, in this area, and we are very keen on working together with all of you in making such a project and such a program happen over the years to come. That's the first point. Second point is that I want to bring this work that we do on health taxes within the context of the broader work we're doing on tax policy in developing countries. We have within our directorate a broad range and a wide range of tax policy topics targeted at developing countries. We ourselves, with the people you've seen, we keep track of the tax measures that countries are implementing, including in developing countries. We keep track on an annual basis of measures that countries implement, and we are increasingly zooming in on developing countries with a specific output for developing countries on the tax measures they've implemented in 21, and that will be a report we will publish in the second half of the year. We do, with colleagues, a lot of work on tax expenditure analysis. We measure the revenue forgone of the fact that many countries have very narrow bases and very many provisions that empty the tax base. And we measure the revenue forgone. We have at the same time projects going on tax and informality, in particular zooming in on the design of presumptive and simplified tax regimes. And you've heard about the work on financing social protection through tax reform and health tax reform. So that's a broad agenda that we try to approach in an integrated approach to bring value added to developing countries. And also here, we're very keen on working with as many partners as we can. So you see on the slide some links to our other work that I was just referring to, and to some of the flyers and brochures that we have available that basically makes it very clear all the work we do and our contact details. Let me now go to the last part. We have, I think we've got 8-9 minutes left. So questions from the chat. There was a question, if I may, I will keep track of the last questions when I ask a question to Celine, but there was a question on how to avoid that, when you increase the tax, that because of the after-tax price increase, that increased smuggling and illegal production. Let me answer that question. At least it's a complex question with many different elements to it, but I think a key point to raise here is that there is really a need for regional cooperation amongst countries within a particular region to tackle the smuggling challenge. And that links very nicely to the fact that health tax issues are indeed international and regional, and so a global approach is definitely necessary. We received another question, Selina, and that's a question for you. It's a bit of a challenging question, if I may say. The question goes as follows: are health taxes, or is health taxes a topic that could be included and discussed within the OECD's inclusive framework on BEPS that brings together over 140 jurisdictions?
Thank you, Bert. That's a very interesting question. Well, the answer is yes, definitively. We spoke about the international dimension of the topic. As you said, Bert, in your final slide, your health is my health. So there is obviously a need here to better collaborate and discuss internationally and also regionally. So answer is yes, definitively, clearly, and that links to the first question you raised. In the case of smuggling, illicit trade, that cannot be solved in silo at a national level. There is necessarily a need for collaboration.
Another question that I saw in the chat, whether we could give very briefly some good examples and practices on taxes on harmful goods. Let me try to give some examples, but I invite also afterwards Celine and Michele and Joya to give additional examples if they pop up in their mind. So good practices on taxes, I think on sugar-sweetened beverages. I think everyone immediately thinks about the example of Mexico, which was one of the first ones, where the need for such a tax was, of course, very dominant, very high, because of the very big obesity problems that the country was and is facing. But that tax actually turned out successful, and there's a lot of literature on that demonstrate that. Another angle, an example that came to my mind is, I think that taxes on tobacco in many EU countries, it's a bit personal experience because we are living in the EU and in my own country, Belgium, is that where the taxes on tobacco are very high, but it is in particular in combination with regulation that these taxes have become very effective, or are becoming increasingly effective. In particular, the ban on smoking in public places, including restaurants, but any government buildings, any public place. I think that interaction of different instruments is a key element for the success of a tax. And that includes also the banning of advertising on television for cigarettes that has been implemented in many countries around the world. Another question for you, Celine. It's again a challenging question, so I bring the most challenging questions to you. I hope you don't mind. The question goes as follows: there are so many international organizations working in this space. Isn't there a risk of overlap?
Thank you, Bert. Thank you for the question. Same answer, yes. There is a risk of overlap, that's very clear. But I mean, I think international organization working on the matter knows, and they know, we are aware of that. So we have created what we call the Interagency Working Group on Health Taxes that meets on Zoom every 3 months or so. Partners are together with us on this. So there is WHO, the World Bank, the UN, and others. And we discuss work streams on the matter. We exchange information. Sometimes we can even review each other's paper to improve and to bring synergies, and also very importantly, to avoid duplication of efforts and to make sure there is consistent messages across organization and as little as possible duplication of work. I mean, the OECD has also participated in a book led by the WHO on the matter, and other projects will very likely continue during the year. So yes, there is a risk of overlap. The good news is that we are all aware, and we are all trying to work to avoid duplication at the country level and more generally on the topic. I hope I answered the question.
Yeah, let me add to that, of course, that we are, as OECD for sure said, that we are working together with other international organizations, and we are part of this in a IAWG working group. There are indeed a lot of players, but we do work together in the future work that we are planning. We are planning to work together with other international organizations. And we get this question often, and it's also important to flag here is that the comparative advantage of the OECD being part of this discussion is that we have a direct contact with ministries of finance. Many other international organizations are more in contact with ministries of health. And the advantage or the importance of advancing this work is to bring these two different ministries together, ministries of health and ministries of finance. That's what we've been trying to do in our work that was kindly funded through the Global Fund. I think that is a particularly successful approach. It is a challenging approach, but you would be surprised how rarely these different ministries talk to each other. And I think the OECD there has an important role, in particular because we have that inclusive framework on BEPS that brings all these ministries of finance from across the world together, where that's an excellent opportunity to bring these health tax issues to them, to make them aware, and for us to be the intermediary to in between ministries of health and finance. I think as far as I've been able to follow the questions, these were the main questions. We also come at the end of this session. I have apologies if I missed a question. Don't hesitate to get in touch with us afterwards. You have our contact details of all the speakers on the slide that will be made available. You've seen the link where you will be able to download them. So thank you all very much for your participation. It was a great pleasure to organize this with and for you, and hopefully see you next time. Bye. Thank you.
Bye.